pain.
Let's move on because there's more stuff here. So because he has a bilateral tear, it's my habit that I do a cervical spine MRI, and we found there's a little bit there, nothing serious. So we move on, and I consent him for a SCR, I consent him for a augmentation, and this time I said I'm going to use your biceps if at all, because I'm going to use that. And so although it was a type 2, there was no tension, I could bring it through. It was not bad quality cuff. So although we had planned for an SCR, there was a stump which could be integrated into the right. So what we did basically was did a biceps SCR, got the biceps in the center, did a double row, got everything back and together. And this guy said, you are going to cut my biceps. I don't like, I've worked my life for my biceps. I don't want a Popeye. So this is the only patient that I have gone in and done a biceps SCR and tenodized the proxima, the distal end. So as it is difficult surgery, long time, but I had to, because this guy's a nutter, I had to go him. I said, don't worry, I will ensure that you do not get a Popeye. So I do this. I know that he's going to, I threaten him, throw the rules book at him, read the riot act. I said, you're not going to do anything. Now, when I did it, I customarily do a spinoglenoid notch decompression for all my patients, and I saw that there was a lot of scarring there, and said, oh, this is not good, and he's had a re-tear. So let's go to the transverse notch, and I do that frequently in complex cases. And we went in there, and this is the left shoulder, and we are right there. If you look here, you can see this is just there, the suprascapular nerve, and as we released the transverse notch, the nerve and artery were both below the transverse. It's a small association, and it's significant there. So we did a transverse notch decompression for whatever it's worth. I agree with Tashish that these are select patients. It's like the carpal tunnel of the shoulder, and it helps. So whether it helps or not is difficult to prove, but you didn't want to leave any stone unturned. And we went in and got this done. That's the decompression. That's the tight transverse notch, and then come in. So doing physio, diligent, supervised this time, again, not allowed to touch the gym. And then at 3 months, he says, Ash, I'm going for a trip for scuba diving. I said, who let you do scuba diving? And then he gives me a half-an-hour lecture of how he sacrificed his life for 2 years and blah, blah, blah. I said, you're not going scuba diving. That's a tough job. He got upset with me, and he thought that it's not going well. So he went in and got his own MRI. I would do a repeat MRI not earlier than 9 months post-op. But he got it done, and till such time that he dispatched it to me, I was like, my other coronary was about to be fired. So I've had sleepless nights because of him and one coronary shot, but he knows that. So this is his about 4 months MRI, and looks everything, including the biceps, holding on there, thank God. But this is his 8 months post-op. He's done this video in the gym for us, especially for this conference. He still does the exercises. I don't think he's done the gym yet, but every month he's emotionally blackmailing me. I need to go in, I need to go in. I'm not so worried. Clinically, I've tested him. He's grade 5 on 5 on the left side. He's full movement. His internal rotation took time to come, especially the GERD, took a long time to correct. It took him almost 6 months. He's pain-free. He's operating. And the right side still remains weak in terms of supra and infra. But this is his status right now. So he's okay. I went through literature. There's very little about revision rotator cuff repair. This paper comes from Brad Parsons' unit, and I think they are quite encouraging. They said good pre-op forward flexion and external were good prognostic factors, but at the same time, the massive tears had more chances of resurgery and failures. Peter Millett's article also said the same thing, that the ASS went from 46 to 76, still worthy of repair if they were repairable. VAS reduced from 6 to 3, which is not a big deal. But reoperation rate again is 5%, complication rate is 12%, which is still worthy of doing that third surgery. But if you look at Boiler's case, very depressing. Tendons did not heal to bone in 36% of his cases, poor clinical and subjective results. So you can read literature both ways and go either ways. But of course, I think fatty infiltration and size of the tear remain strict factors that were poor. Let's move on.
Wait,
Yes.
Rashid. Now, say he tears again.
Yeah.
Then what would you do?
Send him to you or do an SCR. In that order. In that order.
And Ashish, based on how we showed intra-op, this patient I would not have done lower trap on. I just want to make sure clear. This is very clear that I would have done probably what we've done, just slightly medialized, but he did very well. But I would not have done anything. And you agree that he does not need SCR the first time, right? Yeah.
And I think it's important to have repair him because he doesn't have, he has an agenesia of the teres minor, and he really needs to have an infraspinatus in the long term.
Yeah, he's young and he's going to go in the gym, whether you operate him or you don't operate him. And if he goes in the gym on an absent cuff, which is dysfunctional, he's going to be in big shit.
Ashish, which technique used to tenodesis the distal biceps? Onlay or inlay?
Sorry?
For the biceps, to avoid the Popeye, you did tenodesis.
Only.
Onlay. Okay, one screw and sutures.
Yes, but I reposition the biceps posteriorly so that it comes back at the center. You have to create that beam. You can't put it in anteriorly, it will not work. So I reroute the biceps and bring it to the center of the head so that it's perpendicular to its insertion.
Sir, one question.
Yeah.
Sir.
Yes.
Is this case is a good indication for cuff repair, revision cuff repair and the subacromial balloon?
Subacromial?
Subacromial balloon and the revision cuff repair.
Maybe
this
in
is a good
addition to
indication.
this.
Yes.
But perhaps you can afford it, I can't yet.
No, what I said, since he has already 2 times
Yes,
failure.
you're right.
Yes.
Whatever you augment, you must pull out all the stops for him because this is his third surgery, but I have no experience with the balloon. Good. Let's move on. There. So we've got an equitable mix of open and arthroscopic because I know Alex is not so happy with scopes. He likes open surgeries, and this one is tailor-made.
He didn't listen. He didn't listen yesterday.
I agree. So 75-year-old hypertensive, he had seen me 6-7 years back. We had told him he's got arthritis. He didn't bother. He comes from a place which is 600 kilometers from here or probably more. And then 2 years back had some radiculopathy, and 8 years he's had left index finger tingling numbness, but ignored all that. And then finally he decompensated and had severe aggravation and then poor movement. He had right shoulder dominant 130, 40 buttocks, frank OA, and he's got Friedman angle 26 degree, classic B2. This is not the challenge. We know what to do. You can see everything is deformed. T1 side looks good, cuff is good. There's a 26 degrees retroversion, and this was 18 months back. We didn't have the augment that time, and we calculated, did the Friedman angle, and did all this. So I'm going to save you the hassle and go and tell you what we did. Did a bio-RSA on him. So trapezoid graft, we corrected it, and he did the pain was 0 throughout post-op. 6 weeks post-op, his pain was 0, did the rehab and blah, blah. And so around 6 months post-op, I advised them to get a CT scan to find out what's the graft doing, healing, appropriate or not. But he was doing so well that he just did not follow up after that. And he lives in a very remote kind of place, and he kept doing local physio locally every day, which was not indicated, but I didn't know this. And he was driving his 2-wheelers. He's a chartered accountant, still active in practice. And so this was his 3 months post-op. After that, he did well. And then I suddenly heard from him 14 months later, sudden onset pain, dysfunction. Until then, he was 0. VAS was 0. Function was absolutely top class. So what's happening here? Dincha.
Peter, you're.
I suspect he's probably got a stress fracture there. So it would be worthwhile to at least clinically examine him, see where his pain's coming from, and get his imaging studies done for that.
Yeah. So, nothing on the acromion. This was, of course, this is before that. This is 4 months post-op. We still have our graft in there. And this was the time I had advised him a CT scan, but he never did that. This is the comprehensive.
Ashish, one question, Ashish. You said bioRSA?
BioRSA.
Bio, in this kind of prosthesis, biomet, this is the most lateralized prosthesis? Why you did both?
So I don't need to lateralize in the sense if the glenosphere is 36.0, you don't lateralize it. If it's 36 plus 3, then you're lateralizing it. The BioRSA was a wedge graft to cover the Friedman 26-degree angle. So it's like an augment.
This is interesting because this I can ask Alex also. There are one studies, a retrospective study, compared to restore the retroversion with more than 15 degree and keep it less than 15 degree. I mean, to correct the 15 to 0, and the comparison between both without any differences. There are no differences. So why we need, this patient has 17 degree retroversion. Why you cannot keep the same degree and you put it flush and put it 10 degree of retroversion, and maybe with this retroversion, patient has more internal rotation than remove all this retroversion. This is my thought. The first thought. The second thought, you provoke 2 times lateralization. This is too much in this type. This is the most lateralized prosthesis in the market.
Hachem, I agree, I got your concept. This is a prosthesis where I medialize on the humerus and I lateralize on the glenoid side, so you can curtail.
It's only
It is only, yes. But the new comprehensive has an offset on the humeral base plate, so you can mitigate your lateralization. But it was important for me to correct it. And the glenosphere is 36.0, it's not 36.3, it's not 36.6. And you can see, in spite of doing all this, his range of movement is pretty much full.
So Ashish, this patient, until proven otherwise, has a spine fracture. So you need to have a CT.
No spine fracture. No spine fracture.
So no spine fracture.
No
if
spine
you,
fracture.
If you don't see the spine fracture, do SPECT CT.
So I think the other concern.
No, this is the 3 months. There's more stuff coming up your way. One sec. So when the pain started, this is what happened. No, this is 6 month post-op. This is sudden onset pain. This is his movement. I'll get you the X-ray that I want you to see. Those are pretty okay. Those are okay X-rays. This is sudden. From his full range of movement, he's just come back like this. Let me fast forward that. He still has good ear because good graft, but he's upset now. Okay. So this is what has happened.
Yeah, I was just going to say that the acute fracture in a patient at 18 months, if they come back, your implant is jellyfished. And I have 4 cases of aseptic base plate loosening in people who have had this, and all of them were on Prolia. So you have to make sure that the patient is not on, that kind of medication. I don't know if this guy was any kind of osteoporotic.
I was going to come to that. Somebody locally put him on alendronate.
Yeah, so in our series, almost everybody on them is on some kind of a disease-modifying anti-resorptive agent, and all the aseptic loosenings I've had is because of that. And that's why one of my preferences is to use a PEG here because it prevents this from happening, but I've even had PEG base plates, jellyfish. So acute pain, if it's not the acromial spine, it's usually that the base plate's broken, the screws are broken.
You're right. So normally the graft would get integrated at 6 months. I would do a CT scan at 6 months, confirm that it was integrated. It's very unusual after integration that this would happen because then it becomes a load-sharing implant. It's the alendronate that creates all the mess because then it puts the whole process so slow down.
So I have a call out for everybody for this because none of us have enough numbers of this. We all have handful of numbers. And if other people have cases like this, I think we should pool our data and do this. So I've actually, over the course of the last 2 years, stopped all my patients who are on any kind of anti-resorptive medications, and I wait for 6 months before I do the reverse, and I don't let them take anything for a year. Yeah. The endocrinologists hate me for this, but so far nothing has happened.
My question is, Ashish, can the humeral head only you have grafted here?
Yes.
It depends on the bone quality.
Oh, it was excellent actually.
Excellent.
I have photos on those. It's excellent.
We are routinely doing 6 month CT scan. My question is whether the lysis can happen after 6 months.
So when you're on alendronate, it can happen after 2 years. The whole idea of doing the CT scan in 6 months to know that it's hunt curative, at least if there's something to be done, you can do before the screw breaks. Now the damn thing is there are 3 screws broken and they're going to be in the glenoid, and that's going to complicate my problems multiple times. Yes, Rasa.
Ram, I've done, some of the cases I've done, they had no bone grafting done. They were just straightforward implant onto the thing. And when you take this thing out, the back surface is shiny. There is no incorporation at all on it. And so this patient will need a revision now because of the whole situation.
It's exact, Ashish, if you look, and I know, you know this, but in the biomat, even though I'm not a big biomat user, but this central aspect of the peg that usually need to be integrated completely in the bone is in the bone autograft.
No. This is a 40 screw. So the graft is 10 mm. We've got 30 inside on the glenoid.
Okay.
100%. When I use a bio-RSA, I use a 40 screw.
Okay, got it.
No doubt.
Yeah, so I would,
Ashish,
Yes, Raman.
I had the same case. Something has happened, and I discussed with John Sperling as well. The central screw broke, aseptic loosening after around 14 months. B2 glenoid, I did not do a bioassay, I just corrected the version. Still it happened. So I discussed with John Sperling, but because I had used this 28 millimeter base plate, so I was able to fit in the 25 and toggle it to get a different trajectory. But yes, it has happened with me.
Damn, you should have told me first.
I would just say, I think if you look critically at the literature on Glenn bone grafting, while the results from Nice with Pascal are excellent and he's an excellent surgeon, the results are not universally good elsewhere. There's definitely a paper from Mayo that shows high resorption rates. There's a paper from Jeff that shows pretty high failure rates. We are in the process of looking up the results at our institution at 5 years. We previously published those at 2 years. And I will say that the difference between 2 and 5 years is thus far dramatic. There are definitely several failures that occurred after 2 years, and not all of the patients are on anti-resorptives. So I think that bone grafting is a great technique, but I do not think that it has the reputation of being universally successful that it has right now.
Peter, we are on the same page, and that is exactly why I have put up this case. Because I've discussed this with Pascal. Pascal's series is 96% success rate. And till that time I was doing biopsies. This is the first biopsy. I've done about 30 of them, and now this is petrifying. When the first one hits you, you start looking at literature much more closely, and then I went through and there were much more cases that were failing, and it's not obligatory on that graft to get integrated. So this is interesting. There is osteolysis on this case, but it's not completely resolved. Part of the reason could be the alendronate because it's patchy. Some of the graft is still there. I'm going to share some CT scans with you. We're running out of time. Let me run through this case quickly. So I spoke with John Sperling, sent this case to John Sperling. John said, leave those screws in place and you can get by, use a different area, put another base plate and try and get as many screws as possible. In the Indian glenoids, they are so small that sometimes there is very little real estate to put in that additional central screw, and everything leverages on that central screw. So I went in little brave. I used the AO screw removal set, and under Siam, I actually put in the hollow mill and tried to go in as parallel or congruent to that central axis because I wanted to get that central screw out. I managed to get the central screw out with some difficulty, and fortunately we could get all of that out. I left the top and bottom screw halves there because I could dial in and get by the side, and then got in a fresh augmented glenoid. That's exactly what Ashish Gupta had done, and instead of the graft, then I have now a posterior offset there on the augmented side, and you can see on that post-op x-ray, and you can see here that we've got a posterior augment. Just the small one that gives me a 10-degree offset. I didn't correct the entire retroversion. But this is what I meant. This is Pascal's paper, 96% union, and at the same time, he's given his classification. So be very careful when you're doing this because this is Atwal study, the same one that Shirish quoted, that at 2 years, they didn't see any difference between the bio-RSA and the augment. But Marola's group clearly showed that they showed radiolucence lines more about 2 mm in the bone graft in about 36 to 37% of the patients. and also a loss of thickness. That loss of thickness, I think, is much more capricious than radiolucent lines. So if you see that, then you just go on. And the combination that he has a full range of movement is even worse. So
can I just make 2 comments? I think one thing for the audience which is really important is when the base plate screw breaks, this patient needs a revision. He needs a revision. Don't just sit on it and think, hopefully the pain will get better, because what happens is then once it starts toggling, the defect starts becoming so big that it starts becoming an unsalvageable problem. So because you did this really well, you know, it could be salvaged right off the beginning. The second thing I want to say to people is, like, between me and Ludwig's numbers are huge, but I've got a case series of over 200 bone grafts, and as I said, I've only had 4 aseptic loosenings till date. One of the really key important things is not putting just a bone graft, is to really make sure you have bleeding cancellous bone in the glenoid. And that was what I was trying to show today, is that you can't just pepper pot it, you got to get a burr and you got to get the blood to come into the glenoid. And if you don't do that, the graft is not going to incorporate. So the surgical technique for everybody here is really important as well. But revise these people and plan the revision.
thank you. I have 3 more cases. I won't do all of them. We'll do at least this one case. This was actually for George Atwal. Unfortunately, he's just gone, Alex, and he didn't even say bye to you. So, 26-year-old male had left shoulder pain post road traffic accident. Very clearly, he did not have any symptoms before that. I kept asking him, but his active range of movement is just 40, 40, 20, L3, and very painful. And he tried to do some rehab and all that, but it was so painful that gave up after 10 days. So last October, he had an accident, and then he's come back with this very poor range of movement. And let me share the clinical picture with you. And this is the left shoulder that we're looking at. And he's visibly, very overtly dislocating posteriorly. So this is a clear case of posterior instability. And even on the examination on anesthesia, we could easily push it out very easily. You can see and almost perceive that clunk. So I saw some deltoid, there was no wasting, but he had some sensory loss. We got an EMG done. There was an incomplete axillary neuropathy going on. Jerk test was absolutely classic, minor laxity, nothing significant. Infra and horn blowers were weak. This was his X-ray, doesn't give you enough information. I will give you so much. There you go. So you can clearly see he's out of the back. He's sublux almost type 3. The entire head is behind. There's a lot of inflammation. You can see it there as well. Let me share you, for the sake of time, I'll be kind to you and give you this. So this is a clear package. You've got a reversal sacs, you've got a posterior subluxation, and so now what do we do? Alex.
Yeah, go ahead.
Go ahead, Pete.
I was just going to say that there's a lot of complexity going on here. There's obviously what's going on with the glenoid, but there's also, with the prior fracture, but there's also, I think, the fact that his acromial morphology is not normal. His acromial roof is very flat, and he has very poor posterior acromial coverage. So it's a complex deformity of both the glenoid and the acromial side. So I think the most important thing is you don't think that you're going to solve this problem with the soft tissues. I mean, this patient needs a bony procedure.
So what would you offer?
Yesterday I did.
Yes.
I spoke about
Yes.
comprehensive. So this is a bipolar bone loss. It seems the gamma angle is almost 90 degree, but in combination with posterior bone loss. If you take a look at the posterior circle, it maybe has less than 10, almost 10% of glenoid bone loss in the posterior glenoid rim. So it's not, if we go to soft tissue procedures, gonna be fail, absolutely. I would test this under exam. I push the head and try to patient to improve the forward elevation. If pushing the head by under exam without anesthesia, I mean, the patient were able to reach a forward elevation at least 120, it's gonna be for bone block procedures in posterior side.
Yeah.
Definitely.
Yeah. So I kind of missed this because our team does the measurements, and on the measurements we got 22 mm AP diameter, and we knew there was a posterior fragment there. So if there's a fragment, then I say that we do a primary bony Bankart repair. So this one would be a posterior Bankart, so that we gave his native bone black. And then I was going to do a soft tissue McLaughlin there to fill up the reverse hill sac. That was the original plan, because even our radiologists reported something like a 7 or 8% bone loss. So I said that's compatible with an arthroscopy procedure. Clearly I wasn't correct. Yes, Basam, you have something to share.
No,
MRI, yeah. See, because the head is obscuring, it's dislocated, you don't get all the data there.
So Ashish, with this one, first of all, the fracture is not as impressive because it seems incomplete. In some ages, there's plastic deformity more than a true fracture. Myself, I will approach it posteriorly. I will expose posterior. I will use a large osteochondral bone allograft. Expose the head. If there's no cartilage, I can do resurfacing through a posterior approach. He talked about subscap sparing. I can talk about interval sparing between the infra-anterior spinal where you can resurface the head, reduce it, and bone graft. And intra-op, when the patient is not paralyzed under anesthesia, I'll use a checkpoint to make sure the infra has a very nice contraction. And if it is, great. If not, I will add lower trap to keep the stability of the shoulder.
Nandan?
And little bit for me, sorry.
Yeah, there is a bone defect there, and I think we need to give a bone block procedure from the, I think posterior approach, bone block would help.
Okay.
I would certainly suggest you check his muscle strength. If he has muscle weakness there, I think all of that's going to be to naught. So checking his muscle strength, I think the EMG mentioned something about a weakness, significant myopathy or something going on?
No, just an axillary which was recovering. There was reinnervation potential already.
So he had an axillary nerve palsy?
Let's say neuropraxia. Because the muscle power is okay. The posterior deltoid and lateral deltoid are strong. The anterior deltoid is weak, but because of pain, couldn't measure. Okay. The only reason I did an EMG because there was 10 to 20% sensory loss. I presume he's been subluxating for a good part of 4 or 5 months. Yeah. Yes, Achim.
Ashish, another question. If you take a look at this fragment of the bone, at least is up to the coracoid. So it's upper the half of the glenoid, and the shoulder in the posterior side, it pop up between 7 and 9. It seems at 9 o'clock. So this doesn't work if you attach this fragment here. It's mean is if you go to the lower part of the glenoid, it seems a dysplasia, but not this dysplasia. It's because there's an erosion. So it seems. This is what I want to add a graft to restore the anatomy, to put to provoke like a platform to the head. This is because little bit they have a memory.
Okay. So would you do any other investigation for him?
Yes, systematically for this case, I add an anterior remplissage.
Okay.
Yeah, this is a perfect indication.
Sure. Okay, let's get moving.
I would get a CT scan of the other side.
Okay, let's presume that was normal. I didn't expect so much of cartilage change in this guy for a 4.5 month history. And I kept asking him even before, was there anything happening before? But this was clearly gross glenoid bone loss, gross. And I thought I would see a fragment. The fragment was there, but it was just nothing. It was an apology of a fragment. And even the head that started showing cartilage changes. And I was nonplussed. I wasn't prepared for this. So there's no question of doing a soft tissue repair. There's no question of doing a reverse remplissage. So you can see all this. Significant bone loss there. So thinking on my feet, whoever thought we had heard of Kovalchuk procedure in the past. And in this conference, you're getting to hear of it twice. 6 months back, I had a similar procedure and I had read the Kovalchuk, and it was a fantastic article that George et al. Shared. The second author was Jean Grimberg, who's a good friend. So I wrote to Jean about the Kovalchuk, and George said, this is Kovalchuk's procedure. I don't know anything. I was part of the author. We did 10 cases, but I don't know. So I didn't get excited. I left it be. So it was there at the back of my mind. And then I think George gave this lecture at the ASCS, and so that's where I picked up. I removed one of his lecture and put that in. So it was running behind my back. Went in and took a graft from there, impromptu. I tried to get the deltoid on it, but while transferring the deltoid from the posterior end to the posterior tunnel, I lost the deltoid on that because never done it before, and I think I was not very good at retaining the deltoid. So we got a free bone graft. Because he also has a scapular fracture there, I had a limitation of how much. So I just got a 20 mm fragment. So within that 20, I managed to get the arthrolataje set. I just managed to get, just by the skin of the teeth, 2 screw holes there. And oh dear, there's a video missing somewhere here, but I'm sorry. I had a video of the graft coming in. I don't know. So we did the graft and then, sorry, missed that. And we got that 2 screws in there and then did the posterior labrum on that, just hoping that we'll get the graft healing done. But it's very unusual for a road traffic accident and then 4 or 5 months get so much of glenoid wear or wasting. But the fragment's just gone, disappeared. It usually doesn't disappear in 4 or 5 months. So clearly there's a lot happening in there. So for some reason, I don't think I have a video there. There's a beautiful video of the Kowalchuk getting 2 screws in. So where are we? We have 5 minutes. We still have 7 minutes. Let's push this case in there. Last case, promise, so that we finish on time. Quick one, 24-year-old bodybuilder, mechanic, ruptures his biceps. He's a mechanic at the garage and doing the hook test. Distal biceps is intact. He's ruptured his proximal, classic Popeye sign there. And so normally I send all of these guys home. I don't do proximal biceps repairs, but one of our senior colleagues here brainwashed this guy and says, don't come to me, go to Ashish, he will do magic on you. And this fellow, I sent him back, he came back again, he said, do whatever you want to, I need my biceps back. So you've seen, this is another very passionate gym goer that you're seeing today. On the MRI, clearly the biceps is missing completely, nothing else, no other pathology. But this fellow is not only having pain and deformity, he cannot do his gym, he's a passionate gym guy, full of vanity. He came back the 3rd time and said that, just put the biceps back where it is. I don't want it to work, I just want the shape back again. So, anybody, any experience with primary biceps repairs? Proximal.
Yeah, there are definitely vein patients in the United States that prefer the normal contour of the biceps, and I personally think from a subpectoral approach that a tenodesis actually works quite reliably for this, as long as the patient will accept the postoperative restrictions. This is for this patient, he may not wish to be out of the gym long enough to let it heal.
So Ashish, we have close to 20 patients right now. And not like him though, they were symptomatic. They felt spasm. And the problem is when I ask people, do you know why spasm happen? Do you know why spasm happen in the muscle? Why they tell you like you feel a cramp? Not only this. So what I noticed with these patients, I explore them. I want to see why. So the musculocutaneous branch, when it goes in, sometimes it has only one distal branch, sometimes it branches.
Yeah.
When it has a branch proximal to the musculotendinous, when it contracts, it pull on that specific nerve. I have a video interrupt showing it.
Right.
When you pull on it, you can see, like, you get it up, you don't have the pull on the nerve. And we did if it is revision surgery, sometimes you have to be very careful because subpectoral is not going to get it because the biceps could be here.
Yes, that's right.
The best approach is wherever the distal deltoid insertion is anterior to it, not subpectoral, because when you try to go subpectoral, you have to dig. You have to be very careful, you're around the nerve. If you go distal in front of the biceps, deltoid, you're dead on it, you can pull it and you can repair it. And with this outcome, we were very happily surprised. At least 80% of patients, the spasm is gone and they get their motion, they're very happy with it. So this is my approach.
You might be right because I'd never done this before, and when I did this, the 3rd day, he came back and told me that his pain is gone. So I said, it may not work, it will re-tear again. He said, it doesn't matter, pain is gone. And he was clearly discomfort. At night, he had a lot of pain, and he was typically cramping in simple ADLs.
Among these patients, one patient had total shoulder and subscap insufficiency. They sent him to me for anterior transfer versus reverse. But you talk to the patient, they tell you the same. They tell you, like, whenever I feel my pain, and usually you can touch, I have tenderness almost at the tip of the rupture distally. I told him, you know what? Tendon transfer and revision is big surgery. It seems like your symptom localized over the biceps. Let me try to fix this biceps for you, especially if this nerve coming close, and see how we do. He was happy with it. I did it for him. Within a few days, he told me, that's it. I have been dealing with this for 1 year. It's gone. So it's something just to think about. The cramping is from pulling on one of the branches of the musculatus nerve.
I'll tell you another example. The point is when these are gym guys and you think they are non-compliers and you think they're full of vanity, sometimes we tend to disregard that these patients are unimportant. Another patient who came to me from the same surgeon that he'll do it, he had a clear Popeye, and when I examined him, I saw subscap weakness because whenever the biceps is gone, I go and look at the subscap more closely, and I said, you need surgery, but you need surgery for the subscap, not for your biceps. And he said, I need surgery for the biceps, I'm not worried about the subscap. So, kind of convinced him, his wife was very clear, he was a football coach. So, we convinced him, got his MRI, he had only a CT before. MRI clearly showed a subscap type 4 tear. So I said, we need to repair your subscap, you'll be in deep trouble, you're a football coach. So he said, I will agree, but please also do the biceps. So his wife winked at me and said, just tell him yes, because he's not going to listen to you. So I said, yes. When in pre-op I meet my patients when the block was given, I went in to say that, coach, are you okay? We are going to do this fellow. He had tears in his eyes. He held my hands and he said, show me your feet. I said, why? I want you to repair my biceps. And I said, I give you my promise, I'll go and look into it. If it is repairable, I will repair it. So I did a subscap repair. And then I said, since I promised him, let me go and do the biceps repair. I actually managed to find the bicep and put it back in. This guy is so happy. So these are the only 2-3 exceptional patients that have done a proximal bicep repair. But sometimes I think the personality of first case are decision making. Clearly, it's not for the other patient, but this one I've done. And we did it all arthroscopic. There are no guidelines on how to do it arthroscopic. So the thing we did, Basam, was we did a MSK ultrasound and mapped the proximal end and marked it there. And then we knew where the distal end was gone down. And you're right, it was exactly lateral at the deltoid insertion. It was lying there. It was lying there. And I was wondering what I need to do and go down. It was not necessary to expose the pec major at all. In fact, the pec major insertion was a good landmark for us to take us through laterally, guide it down. But the pre-op ultrasound clearly told us that it's much more superficial, and so you could just pick it up. But we had to do a ladder technique because we had to build up the biceps and pull it step by step through 3 different portals, and then we did a biceps tenodesis right there in the groove, upper part of the groove. So you could manage to bring it up, and surprisingly it is quite flexible. This is his post-op. I have not allowed him to do gym yet, but he's back to his mechanics job. He's got his Popeye corrected. Strength looks good.
Ashish, I didn't understand. Why were you reluctant to do a biceps tenodesis? This was an acute subscap with biceps. You're going to do this?
No, this guy is not a bicep. This is not a subscap. This is a pure biceps, pure isolated biceps. The football coach was a different patient. So that's why I wasn't sure what the success rate was and would it benefit him or not. But clearly he was persistent. I'm glad I did this. So he's done well. Literature, there's a splattering of literature, nothing special, but there's a re-rupture. But all of these guys are wrestlers. And this article had about 7 patients, and all of them, 6 of them did very well. 1 of them re-ruptured. But clearly they allowed all of them to get back to wrestling, and they have done well.
Just as a quick point about this, the main reason I think for the subpectoral approach is that the anatomy of the proximal biceps is that the musculotendinous junction is 1 to 2 centimeters above the lower border of the pectoralis.
Yes.
So the reason to take that approach is then if you use that as a landmark, you can get the tension right and avoid the tension on the nerve. So I agree that you have to be cautious about the nerve, but I don't think you want to make just a distal approach. If you do the tenodesis there, then you haven't restored the proper length tension relationship. So that's, I think, the main reason why the subpectoral approach is so helpful is because that's the only landmark within the proximal biceps.
Yeah, don't do it in too much of elbow flexion because they can get an elbow contracture and you can add to their pain.
So this is the beauty, though.
Yeah.
If you put it 1 to 2 centimeters above, it doesn't matter where the elbow is because you've restored the right length tension relationship. Yeah.
So, but just to add to this, even without an ultrasound, when you see the Popeye sign, and can you hold it? Just if you look at it and you see the biceps here, this is a tendon. Look at the pect. The tendon is here.
Yeah.
So even if you have still a stump, you are still here, not here.
Yeah.
You can see it bunching up and the tenderness is here and this is a pectoralis major. All that I'm trying to say, sometimes we are used to the subpectoral and this is what happened to me one time. And I have to make it to dig down because it was at least 3 centimeter distal. And this area is very, very, for me, I'm a nerve surgeon. This is the tricky area because as a skinny patient, you can end up within the brachial plexus.
Yes.
Once you get beyond. So this is why this is much safer if it is distal. This is what I'm trying to say.
Super. Thank you very much. I think we'll call it a day. We are bang on time. Really appreciate. Thank you for staying back. Have a safe trip back home. And we'll meet in February 2025 for the arthroplasty. It'll be a much smaller meeting, pure arthroplasty. But thank you. Love you all. Stay blessed. Good day.
There's no other place in the world like Vancouver. The scenic beauty, the incredible people. I was born and raised here and did my medical training at UBC. Coming back, it's like falling in love all over again. Vancouver is so welcoming. It's becoming a global leader in hosting successful international meetings. The convention center is a marvel. It feels like you're connected to nature, the mountains, the ocean, even when you're inside. I know the people, I know the city, and hosting an event in a venue like this will be truly memorable. I can't wait to welcome my colleagues and show them around this beautiful city.
We're really excited to be here, George. Thank you so much. Cheers.
Cheers. How was your